Also, Patanga.
Hi. Okay. Right. So today we start neurology, and we will do this in sort of 3 sessions. So today's session is on headache, cerebrovascular disease, and infections of the nervous system. Right. Now the first few MCQs are on headache. Right. Now headache, as you know, is a very common disease, and we can give you 1 or 2 MCQs on headache at the exam. Right. This slide shows you that the classification of headache can be complicated, right? Broadly, we have 3 categories of headache, right? So primary headaches, which include migraine, tension type headache, right? Secondary headaches, which you have headache secondary to some other cause, for example, an infection, right? And also you have painful cranial neuropathies as the third group, which includes things like trigeminal neuralgia, right? Now, each of these disorders have a very specific definition, and there is a whole book put out by the International Headache Society, which gives you a very detailed diagnostic criteria for each of these types of headache. Right? So at an undergraduate level, we don't expect you to know details about this, but you should know this classification as primary, secondary, or disorders of facial pain, painful cranial neuropathies like trigeminal neuralgia. Now the first question is about migraine. Right. Now the typical story of migraine is that they can present with an aura, right? They can present with an aura, which is often flashing lights or scintillating scotomas, right? Zigzag lines, right? And that sort of thing, right? Which are mostly visual in origin, right? They can have an aura, but remember, an aura is not common in migraine. So if you take 100 patients with migraine, only about 20 or so will have an aura, right? So it doesn't commonly cause an aura, right? Most often it doesn't cause an aura, right? So in the traditional textbooks, they describe migraine with aura, migraine without aura. And if you look at the epidemiology of the 2 disorders, actually migraine without aura is common, right? Hari. So commonly presence with aura කියන එක වැරදි මේ MCQ එකේ. Doesn't commonly cause an aura. It can most often presents without an aura, right? Okay. And the other thing is, remember that migraine is usually unilateral and typically described as retroorbital, right? And it is a throbbing type headache, which is unilateral. Most of the time it is unilateral, right? So මෙතන bilateral කියන නිසා වැරදි, right? So that is important to mention. Migraine is also common in females and not in males, right? Okay. So these are important things. Now, the traditional teaching was that migraine was not associated with any structural brain changes and everything was sort of functional. But there is recent evidence to suggest that over time, patients with migraine can have atrophy of certain parts of their brain and structural brain alterations. So the last one is also true, right? Okay. Now, how do we treat migraine? So this is sort of the diagnostic criteria for migraine. So as I mentioned, you can have an aura, right? But that is not common. And it is usually unilateral and throbbing in nature, right? Another important feature of migraine is it is associated with photophobia, phonophobia, nausea, and vomiting, right? So putting everything together, you can make a diagnosis of migraine. Usually headache episodes last for at least 4 hours, right, at a stretch. Right. So we have done 1, 2, and 5. Now, how do we treat migraine? If you remember this, migraine treatment is divided into 2 components, right? One, we have a treatment of an acute exacerbation, right, where 5-HT1 agonists like triptans are very useful in acute attack of migraine, right? Also, we use things like NSAIDs and paracetamol. Also, remember that metoclopramide has a good effect on acute migraine, right? Antiemetics. You would have seen this in the wards. A very effective method of giving intravenous metoclopramide as an antiemetic, and that actually improves the headache as well. So these are all strategies for acute management. Triptans are 5-HT1 agonists, and there are certain other sub-drugs that we use. Now, prophylaxis is usually recommended if somebody has more than 2 episodes of migraine per month. But take a හැම වෙලේම දෙකක් වෙනකන් ඉන්නේ. If even one but very severe, you will still consider it. But the guidelines will say දෙකකට වැඩිය තියෙන්න ඕනේ කියලා. And we use a range of drugs. Common use drugs are things like propranolol, right? And we also use calcium channel blockers, right? And also people have now we have now used things like topiramate, which are anti-epileptics, which have a reasonable efficacy for migraine prophylaxis, right? Cases that are resistant, we sometimes give injections of botulinum toxin, and that also works. And there's a whole new avenue of treatment for migraine prophylaxis, which is based on antibody-mediated therapies, which are not available in Sri Lanka. Hari. Okkoma diagnostic criteria, you should have, I can't remember how many you need, but headache has to have 2 of the following 4 characteristics, at least one of the following, right? And you should have B to D, but within that there is a sort of a relaxation, in the headache characteristics, etc. Right, so coming back to this, 5-HT antagonists, agonists, so triptans are 5-HT1 agonists. Preventive therapy is indicated if the patient presents with 2 or more episodes a month. So that is right. Right. Okay. So this is just a quick overview of migraine diagnosis and treatment. Right. Any questions on this one?
Sir, more of a general question. In MCQs, when you get words like commonly, exactly like, I mean, it's a little vague, sir, like how common is commonly? Is it like
commonly at least more than 50%, yes. At least more than 50%.
Right, okay.
Harry?
Good. Excuse me, sir.
Okay.
My question is 5H2 antagonist, episode acute දෙන්න බැරි වුණාට මේ prophylactic දෙනවනේ සමහරක් කර.
It's an effective name, right? So they're not, they say they are effective. So we don't usually recommend those used for sort of acute. Even for chronic things, there are better drugs to use. Yeah.
Right. And අර මේ අර sumatriptan අර අපි acute දෙනේවා මේ prophylaxis දෙන්න බෑනේ. ඒක දෙන්න.
The prophylaxis දෙන්න බෑ, but there is one instance where you can use it. So it's useful in this situation. It's not strictly prophylaxis, but somebody who has migraine with aura, when you take the sumatriptan with the aura, the headache can go away. So aura so some people argue that this might be prevention, but when you take it with the aura, it sort of relieves the headache or prevents the headache from coming on, right? So that is sometimes used in that situation. Triptans.
Right. Thank you.
So botulinum toxin is injected around the orbit, right? Into the sort of in the periorbital region, into the muscles, temporal region. Yeah. Right. Okay. Now then, in your headache classification, there is a large group of headache disorders which are called trigeminal autonomic cephalgias, right? Trigeminal autonomic cephalgias. They are called trigeminal autonomic cephalgias because the pathogenesis is related to the trigeminal nerve. So there are disorders of the trigeminal nerve that cause these headaches. Now in that, there are several types. Sorry, table but of course the commonest type is, the most important type is cluster headache. There are some other types also, for example, things like paroxysmal hemicrania, sunk, right? Those are rarer, and I don't think you need to know very much about them at the undergraduate level. Right? So cluster headache is an important thing you need to know. Right. Now cluster headache is common in males, right? It's much more common in males. So it's now the typical story of a cluster headache is that it's commonly around the orbit, so it's periorbital, right? Periorbital. And the word cluster comes up because these people get clusters of headaches. These are usually 15 to 3 minutes to 3 hours with a last for, and they are sort of clusters. They come in clusters, right? So for example, satiyaka dawas deka tunak vitara එක දිගට එනවා. Then you don't get it at all. right? So that is the clustering of these headaches, clustering, right? So sometimes you get a month where you have a cluster of episodes, right? සතියක දවස් 3ක් විතර එක දිගට එනවා, then you don't have it for a while, right? So that is the typical story of cluster headache. An important feature, as you might guess, because there is involvement of the trigeminal nerve, is they get a lot of trigeminal related sort of autonomic trigeminal nerve territory autonomic manifestations as well, right? ඒ වගේ දේවල් එන්නත් පුළුවන්. So attacks can be associated with Horner's syndrome. Each episode lasts for less than 5 minutes, at least 15 minutes. If it's shorter, it could be another type of trigeminal autonomic cephalgia, right? For example, things like paroxysmal hemicrania or sanct vage level. The other types last for shorter, right? But remember, in cluster headaches, the episodes are sort of 15 minutes and above, up to about 3 hours max. To make a barrel, right? Now, an important diagnostic as well as therapeutic modality in trigeminal autonomic cephalgia, especially cluster headache, right, is to give 100% oxygen, right? And that can be therapeutic as well as diagnostic. When somebody comes with a history suggestive of cluster headache, you give them 100% oxygen and the headache improves. That is, you have the diagnosis as well as it is a therapeutic option, right? There are other drugs that we use in acute episodes, that is sumatriptan. Sumatriptan is very useful, especially nasal sprays are very useful, right? In patients with cluster headache, we also have prophylactic therapies like calcium channel blockers are commonly used as prophylactic therapies. Right? Calcium channel blockers are just prophylactic therapies. Right. So sumatriptan, which is a 5-HT1 agonist, is used in effective in acute attacks. Right? So the two first-line drugs we used for acute attacks is 100% oxygen as well as sumatriptan. Nasal spray is very effective. Sumatriptan nasal spray is very effective for these headaches. Right. So this is a group of disorders with a clustering of short-lasting sort of 15 minutes, but can go up to 3 hours. Periorbital pain, which is usually unilateral, right? And they have a lot of autonomic manifestations, Horner's syndrome, you get lacrimation, right? A lot of autonomic manifestations in the distribution of the trigeminal nerve, right? Okay, right. Any questions about that? MCQ number 2. Right. The next question is on trigeminal neuralgia. So this is going into the third group of headache syndromes, which are disorders of facial pain, present with facial pain. Right. Now, trigeminal neuralgia is commonly actually presents for the first time in usually middle-aged to elderly wage tamai presentation. Doesn't occur in adolescents very commonly. Right. Mid-age, and it's commoner in females as far as I can remember, but please check. Right. Now, occasionally, right, trigeminal neuralgia can occur due to a vascular anomaly in the superior cerebellar artery, right? And in patients with resistant trigeminal neuralgia, you have surgical interventions that can relieve this compression, right? So that is right. In trigeminal neuralgia, the ophthalmic division is usually not affected. It is mostly the maxillary division that is affected, right? So ophthalmic division එක සාමාන්‍යයෙන් affect වෙන්නේ නැහැ. It is usually the maxillary division. Now, despite trigeminal neuralgia being a trigeminal nerve problem, it is a very important clinical point that you will never ever get sensory signs or motor signs in the trigeminal nerve distribution, right? ඒක කවදාකවත් වෙන්නේ නැහැ. If that is the case, you have to think of an alternate pathology, like, say, example, a tumor or something in the trigeminal nerve territory, right? Compressing the trigeminal nerve. Even though they say there might be a vascular anomaly, you will never ever get sensory signs or sensory symptoms in the trigeminal nerve distribution. If you do, you can exclude trigeminal neuralgia and it is due to something else, right? So this is false. Invariable කියන්නේ අනිවාර්යයෙන්ම තියෙන්න ඕනේ. Just be essential කියන එක තමයි invariable කියන එකෙන් කියන්නේ. Right. And how do you treat? Carbamazepine is a very frequently used medication, right? Carbamazepine is a very frequently used medication. Right. Any questions?
So when you say there's no sensory signs, I thought they get this hyperesthesia with
signs, hyperesthesia, it's just you can't objectively prove that there's sensory signs, right? So that hyperesthesia is more of a symptom rather than a sign.
Right, okay, sir, I got it.
Right.
Excuse me, sir. May trigeminal neuralgia sir secondary trigeminal neuralgia කියන එක ඒකේ sensory signs මොකද එන්නේ බයි?
දැන් එතන secondary කියන වචනේ trigeminal neuralgia වලට පාවිච්චි කරන්නේ by definition because trigeminal neuralgia is a primary cause of facial pain. Secondary trigeminal pain can be due to something else, right? So that secondary trigeminal neuralgia term is not very here. We are referring to the sort of primary form of it, right? Of course, if there's a tumor compressing causing facial pain, then you will get some sensory loss or motor problem. Yeah. In the
right.
Yes, it can cause mandibular pain also, but mostly maxillary region tamai in neck. Right.
So, neuroimaging always indicated?
Always, no. So, neuroimaging is indicated if there is any suspicion that this is something else, right? For example, if you find objective sensory loss or motor weakness in the trigeminal nerve, yes, you would do imaging. Another instance for imaging is patients who have trigeminal neuralgia that don't respond to medication. You'll do an MRI and MRA to look specifically for the aberrant vascular branch of the superior cerebral artery, because then you'll be considering things like surgery, right? If there are atypical features, yes, or if there is treatment non-responsive disease where you are considering surgery for this looking for this aberrant superior cerebral artery, then yes. Right. Now the next series of MCQs are on stroke. Right. Now, stroke, remember, there is a very specific definition for stroke which you have gone through during your long cases, and you know that definition, right? So, as sudden onset focal or global neurology due to a vascular cause, right? And the symptoms commonly last for more than 24 hours. Right. People are revising this classification now in various ways, but that is a traditional classification or definition. Now, say stroke can be ischemic or hemorrhagic, and the ischemic strokes are divided into further groups based on the TOAST classification, right? So TOAST classification is more of a mechanism-related classification, right? So, for example, it will include groups like atherosclerosis, cardioembolic. So this is mostly a etiology-based classification, right? And of course, for ischemic stroke, we also commonly use this classification, right? All of you should be familiar with this classification. We've talked about this in the long case and in your appointments, right? So this is based on the vascular territory that is involved, right? So based on the vascular territory that is involved in ischemic stroke, you would say, okay, this is an anterior circulation syndrome, a posterior circulation syndrome, or a lacunar circulation syndrome, right? And that is based on the vascular territory of involvement in an ischemic stroke. And this is called the Oxfordshire Community Stroke Project classification. Right. True or false regarding stroke is most often due to atrial fibrillation. අනේ මේක මේ ischemic stroke කියලා හදාගන්න, sorry. Okay, ischemic. Right. True or false regarding ischemic, most often due to AF, no. The most common cause of stroke is atherothromboembolism. So what happens is, on a pre-existing atherosclerotic plaque, there is rupture of that atherosclerotic plaque, giving rise to a thrombus. When the atherosclerotic plaque ruptures, you get a superimposed thrombus on that rupture point. And that breaks off small pieces, giving rise to embolism. So it's atherothromboembolism into the cerebral vessels. Right. So that is the most common etiology, but yes, atrial fibrillation and cardioembolic stroke is also an important cause, but it is not as common as the atherothromboembolic stroke. Right. Now, this is something that I told you. The second point is something that I told you in your appointments also. You cannot differentiate an ischemic stroke from a hemorrhagic stroke using the history and the examination. You cannot do that. It is impossible, right? And you need a CT scan to do that. There is no way of doing it otherwise. There is no clinical scoring or clinical criteria that you can use to differentiate. And this is why I said if you work in a hospital where there are no CT scans and somebody comes to stroke, you should immediately transfer the patient. Of course, after ensuring the patient is hemodynamically stable and the vitals are stable, to somewhere there they can do a CT scan, right? Now, expressive dysphagia is a feature of an anterior circulation stroke syndrome, right? But it is a dominant hemisphere, dominant hemisphere. Now, in the last part of these MCQs, we will talk about the features of a dominant hemisphere, non-dominant hemisphere disease in more detail. But this I have taught you before. Expressive and receptive dysphagia is a dominant hemisphere lesion, and this is wrong, therefore. Right. Okay. Now, the posterior inferior cerebral artery or PICA syndrome is a very famous posterior stroke syndrome. Posterior circulation stroke syndrome. Right. So PICA supplies this area, right? As you see in this slide, right? And that does not involve the motor pathways which are down below in this part. When the motor pathways in this anterior aspect, right? The pyramids right? So that PICA, or in other words, we call this lateral medullary syndrome, does not cause any hemiparesis, right? Because it is a lateral disease, right? And the anteriorly you get all your motor pathways, they are anterior. So occlusion of the PICA causes contracted hemiparesis, right? Now, the last statement is again something we discussed during your prof appointments. When you have a posterior cerebral artery, there is another posterior circulation stroke syndrome. When you have a posterior circulation infarct, right, you get macular sparing and homonymous hemianopia. And the reason is because the macula is supplied not by the posterior cerebral artery, but it is supplied by the middle cerebral artery. Macular region or the macular representation on the occipital cortex is supplied by the middle cerebral artery and not the posterior cerebral artery. So therefore this is wrong, right? But I told you at that point, when there is a tumor infiltrating the occipital lobe, it does not stick to vascular territories. So therefore you would get macula involvement, right? But if it's a stroke, it is very clearly the posterior circulation, posterior cerebral artery territory. And the macula is spared because it is supplied by the middle cerebral artery branches. Right. Any questions about 4? Right. So, progressively deteriorating neurology in hemorrhagic stroke again cannot clinically differentiate, because even in an ischemic stroke, if it is a big infarct, you get worsening cerebral edema, right? So then the patient can get progressively worse, they can get unconscious. So it's difficult to differentiate based on that as well. Hi. Okay, any questions about this one, Q4? We're just talking to you through the various classifications of stroke: anterior circulation, posterior circulation, and also some clinical signs. Right. So this is just a description of the macular region, how it is supplied by the middle cerebral artery branches. All right. Okay. Right. Now, when you have somebody come in with an acute ischemic stroke, we've talked about this, you would request a non-contrast CT of the brain. And the main idea there is to, get exclude a hemorrhage. Anterior circulation. So again, in anterior circulation, you don't commonly get hemianopia. What you get is quadrantanopia, and that is because the optic radiation fibers pass in 2 bundles through the parietal lobe and the temporal lobe. Right? So parietal lobe get disrupted, and you get a quadrantanopia, right? Homonymous quadrantanopia, not a hemianopia, right? And internal capsule infarcts do not cause hemianopia. Right, so we're talking about the initial management of ischemic stroke. So get a CT scan and exclude a hemorrhage. That is the first thing that you do, right? And in the CT scan, you will see that there is, this is all an infarct, right? Sometimes we do MRIs also to diagnose ischemic strokes, but because of the lack of access, and it takes a lot of time to do an MRI as well. So it is not really done in the acute management. So CT scan is more than enough for acute management. You don't need to do MRI scans. But the problem is in some of the earlier in the disease course, it might be difficult to see an infarct on a CT scan, right? නිසා පස්සේ කාලෙක අපි සමහර වෙලාවට confirm කරගන්න we will do an MRI scan later, but that is not essential in the acute management. Right, so first one is wrong. It's not the preferred modality. Several reasons for that. We don't have MRI machines freely accessible. It takes a longer time to do an MRI. And also possibly MRIs are not very good at picking up early hemorrhage, right? That is another reason. Right. So MRI anyway, CT, non-contrast, plain CT scan is more than enough for you to make decisions. Right. Now, we never ever give loading doses of aspirin. Statin දුන්නට කමක් නැහැ, but never aspirin on suspicion of stroke, right? Because you never know, as I told you earlier, you cannot clinically differentiate between ischemic and hemorrhagic stroke, neither, without doing a CT scan. So on presentation, you never give aspirin loading doses for patients with stroke. You have to do a CT scan to exclude hemorrhage before you give any sort of antiplatelets or thrombolysis. Right. Now, as I mentioned in this slide, one of the main objectives of acute management of ischemic stroke is to see if your patient is suitable for thrombolysis. And this is the common form of reperfusion therapy that we do. We make thrombolysis අපි පාවිච්චි කරන්නේ reperfusion therapy විදිහට. So, now what about thrombolysis? So in Sri Lanka, we have well-functioning thrombolysis programs in the big hospitals. And remember that thrombolysis is effective only up to 4.5 hours of symptom onset. Right? Maximum you can go up to is 4.5 hours. Right? Thrombolysis in a standard setting of clinical care up to 4.5 hours. So make a boru kataවක් එක වැරදි. Right. Now also remember that when a mehema කතාවකුත් තියෙනවා, right? If your patient falls into the 3 to 4.5 hour time window, there are additional exclusion criteria that you need to consider. හරි? ඒ ටික ඔය 4 ඒකත් මතක තියාගන්න, and this is all coming out of clinical trials. Some of them don't have a clear explanation as to why. Right? For example, history of both diabetes and prior ischemic stroke. It's difficult to explain why that is a exclusion criteria, but it comes from clinical trials where they modeled the outcomes, right, at these time points. So this is very important, right? So if your patient presents beyond 3 hours, there are additional exclusion criteria to exclude. And by the way, the NIHSS scale method, that is a NIH stroke scale, which is a score that you can use to measure the severity of the stroke and method DNA. Right. So thrombolysis can be effective to 4.5 hours, but remember, if they are in the 3 to 4.5 hour time window, there are 4 additional exclusion criteria that you need to think of before giving thrombolysis. Right. Now, this I also mentioned, the next statement, I also mentioned during your clinical appointments. I told you that over the last few years, there has been a major development in ischemic stroke management with the start of thrombectomy, right? So in thrombectomy, what you do is, right, like shown in this picture, you put a catheter up and sort of you can pull out or aspirate the clot. Now this is currently used for large vessel occlusions, large vessel, podi chutu perforating lacunar vessels, you cannot utilize this method. The main use of this method is to go for clots in big vessels like the or proximal MCA, right? And also we know that this mechanical thrombectomy can be effective beyond that traditional time window of 4.5 hours. So the initial trials, up to 6 hours, it is still effective. And now there is some further recent advances, which I will just briefly mention next, which can extend this time window up to 24 hours from symptom onset. So this is, so remember, in order to do or consider mechanical thrombectomy, large vessel occlusions කියන එක වැදගත් නේද? Either internal carotid or proximal MCA. Right. Now we talked about blood pressure management in stroke නේද? ඒක ගැන අපි කලින් කතා කරලා තියෙනවා. And remember that the problem is that in stroke there are several things that happen, right? In stroke, ischemic stroke, there is a area where your neurons are dead. Nothing you can do about it. That is an infarcted core. Around this infarcted core, you have an area called the ischemic penumbra, right? And this ischemic penumbra is perfused because your body, as a response, elevates your blood pressure. So the elevation in blood pressure is a physiological response, and it is done to provide blood to this ischemic penumbra, right? And the blood is driven into this area because of the high blood pressure. And additionally, in this area of ischemia and infarction, the cerebral autoregulation is also defective. Right? There are ප්‍රශ්න දෙකක් තියෙනවා. එකක් තමයි high blood pressure එකෙන් perfusion එක තියාගන්නවා. But the autoregulation is also effective. So what happens if you drop the blood pressure too fast? That area is going to be compromised. Right? The flow to that area is reduced, and there is no autoregulatory defense. නේද? සාමාන්‍ය blood pressure එක චුට්ටක් එහෙම වෙනකොට blood flow එක හදා ගන්න පුළුවන් because of autoregulation. But here the autoregulation is also gone, and when you drop the blood pressure, it can cause infarction of the penumbra, which you can save. So the blood pressure එක ගන්න නැහැ. සාමාන්‍යයෙන් 220, 120 if the patient is not undergoing thrombolysis. That is the threshold. And if your patient is undergoing thrombolysis, you go for a lower target like 185, 110, right? And why do you go for a lower target blood pressure if you are thrombolizing? Because of the risk of hemorrhage. Thrombolize කරපු ගමන් there is a risk of hemorrhage. So blood pressure should be managed aggressively. Katandara less than 180, 280, that is absolute bullshit. In ischemic stroke, you never do that. And this is because of the problem I mentioned. So in a patient who is not undergoing thrombolysis, you have a higher threshold, like 220, 120. But if your patient is undergoing thrombolysis, then the threshold becomes lower at 185 over 110. And the reason there is because of the risk of hemorrhagic transformations. You want to control the blood pressure a little bit more strictly there. Hiran, you mixed thrombectomy up with carotid endarterectomy. How is it? So this 99% thing is with carotid endarterectomy, not thrombectomy. Carotid endarterectomy is a completely different thing. Right. So we've talked about this. Now, another recent development in stroke management, and I briefly mentioned this a few minutes ago, is that now we are able to do perfusion scans. Right? This can be CT perfusion scan or MRI perfusion scans. So make a ලස්සන්ට බලන්න පුළුවන් as shown in this picture. මේ purple part තියෙන්නේ ischemic මැරිච්ච කෑල්ල. හරිද? වටේ තියෙන එක penumbra එක වගේ. Right? So that is the sort of, that's not dead yet, but it's at a risk of dying. So that's a penumbra. So what people argue now is, regardless of when the stroke started, if you have a higher salvageable area compared to the infarcted core, right, then you'd still do things like thrombectomy, and that has shown to be beneficial, right, up to 24 hours, current evidence, right? So if your ischemic penumbra is bigger than your infarcted core, you can still do various forms of reperfusion, right? Thrombectomy definitely yes, and there are some trials now which look at thrombolysis as well after doing these perfusion scans. And these are available in Sri Lanka. You can easily do these scans in Sri Lanka. They just require a little bit of a modification of an existing CT machine. Right, software modification එකක් තමයි එතන වෙන්නේ. Right. So nobody's going to ask you about this in the exam, but just as I mentioned. Right. Okay. Now this question number 6, right? So question number 5 done. Any questions about question number 5?
Yes, sir. Sir, could you explain a bit about, you briefly touched on this NIHS score more than 25. Does that go in line with this? We learned something else called this MCA artery, infarction more than 1/3.
Oh, it is in a way related, right? Now, the point is that if you have a very large infarct, right, very large infarct defined by an MCA territory or involvement of more than 1/3, right? Or if the NIH score is very, very big, that indicates a very severe big infarct. That is a relative contraindication, or you have to be careful when you're thrombolizing those patients because there is a higher risk of hemorrhagic transformation. So if the MCA territory involvement is more than 1/3, or even if the NIH score is very high, and these are big territory infarcts, that would increase the risk of hemorrhagic transformation following thrombectomy. Also, the outcome is not very good also because these are established very big strokes, and even if you thrombolize them, their outcome is poor. Right? So the risk is higher than the benefit, in other words.
So, sir, is it that slide?
It is an exclusion criteria in this context, but this MCA 1/3 is a relative contraindication. Yeah.
Right. Okay. Yeah.
Right. Now, question number 6 is sort of focusing on, we have talked about the acute management and then now the subsequent management. So first statement is, so this malignant MCA syndrome is something that I briefly touched upon earlier. So sometimes you can get a massive MCA infarct and there is significant cerebral edema around the infarct, right? And this can cause midline shift, right? And the patient can become unconscious because of the midline shift, midline coning. So in those situations, decompressive craniotomy is something that needs to be done and that improves outcomes. There is clear evidence that it improves outcomes, right? There's a lot of pullback from the neurosurgeons, but there is a lot of evidence that this really works. Right? So it's a right. Now, where should you manage a patient with stroke? Again, trials clearly show that the outcomes of a stroke patient when they are managed in a stroke unit are much better than when they are managed in a ward, on a general ward. The main reason for that is in the stroke unit, they get 1-to-1 care. There's usually a 1-to-1 or a very good nurse to patient ratio in these stroke units. They get very good attention. In addition to this, in a stroke unit, you'll have a whole load of specialists around you, like specialist speech therapists and language therapists, occupational therapists. Right? These are all your colleagues when you're managing a patient with stroke. Right? So that's very important. It's a team-based environment. Team-based, you work with everybody in a team, right? And this nonsense, one langadi dakka, when the later on Facebook, somebody had put a letter, referral letter, where we addressed a nursing officer as a colleague. Right? And there was a lot of pullback from various people that this is a wrong thing to do, and it's absolute nonsense. Right? Of course, these are your colleagues, right? And why do you need to treat your nurses differently and your therapists differently, right? So these are the mentalities that you should change that are horrible in Sri Lanka, right? Here, of course, there is nothing like that. There is no hierarchy. And hierarchy, nurses and doctors are right? There's also, for example, a house officer has the same sort of respect as a consultant. Everybody is part of a team, right? There is no hierarchy, right? So in a stroke unit, everybody is important. It is a group effort to make the patient better, right? So these sort of petty nonsense, please don't practice when you become house officers. Everybody is your colleague and everybody is your team member, right? So management of stroke in any case improves functionality, very clear, right? Now, after a stroke, you should focus your main attention on obviously getting the patient better and almost back to their baseline functional status. But it's also important to prevent further strokes. And an important thing to do is give them antiplatelet therapy, right? Antiplatelet therapy. Now, antiplatelet therapy, what we usually do is we give them aspirin, right, initially. And this various countries have different approaches. Sometimes you give it for a month and then switch to clopidogrel, right? Masak විතර aspirin දීලා, then you switch it to clopidogrel lifelong. Various other parts of the world have different approaches to this. සමහර අය මාස 3ක් දීලා මාරු කරනවා, whatever is okay, right? We do not commonly use dual antiplatelet therapy. Right? Commonly, dual antiplatelet therapy is not recommended except in the situation of minor strokes, right? Very minor strokes, and also TIAs. And this again, 3 months maximum, then පුළුවන් dual antiplatelet. Right? Like you do an MI, අපි සාමාන්‍යයෙන් MI වල ගොඩාක් කල් දෙනවනේ, අවුරුද්දක් දෙනවනේ. Stroke වල එහෙම කරන්නේ නැහැ. You can consider it in patients with minor stroke or TIAs for a period of 3 months. So make a වැරදි හැමෝටම දෙන එකක් නෙවෙයි ඒක. Right. Okay. Another important thing that you do is, right? Important thing that you do is that you also do a carotid Doppler, right? And patients with significant carotid occlusions, right? You will refer for carotid endarterectomy. Right. Tapparak denna, sorry. I have to answer this. Right. Sorry. The සාමාන්‍යයෙන් අපි කියන්නේ if the carotid narrowing is more than 70%, that is a clear indication for carotid endarterectomy. Right? But only up to 99% occlusion. Right? 100% occlusion වලට කරන්නේ නැත්te හිරන්, because in a 100% occlusion, even if you take it out, there will be no effect. Because what happens is the whole circulation, when you have a 100% occlusion, is driven by the other side. So even if you open that occlusion up, and that's over time, it sort of adapts to circulate based on one side, right? And even if you correct that 100% occlusion, there is going to be no effect. Right? So that's why we don't correct 100%. So it's 70% to 99% occlusion. There is benefit in going for carotid endarterectomy. Right. මේක වැරදි 50ක් එක නෙවෙයි 70ක්වත් තියෙන්න ඕනේ. Right. Now, another very complicated scenario arises when you're thinking of secondary prevention in strokes following AF. Now, this is a bit of a delicate problem. Right. Now, you know that if you have a patient with AF who comes to the stroke, this is due to a clot, clot breaking off, or in other words, cardioembolism. And obviously, you should anticoagulate the patient. There is no doubt about it. But the problem is that anticoagulation can also cause bleeding transformation in acute stroke, right? So depending on the size of the infarct and the severity of the infarct, you will have to delay the commencement of anticoagulation. So, right. So make a දැනගන්න, but if it's a minor stroke or TIA, you can start anticoagulation almost immediately, 1 to 3 days after the event. But if it's more severe, we usually have to wait for about 2 weeks before starting anticoagulation. Right? And that is the guideline. This is European Stroke Association, a standard guideline. Why you don't start it immediately if there's a big stroke is that it can cause hemorrhage into the infarct. So you wait for about 2 weeks before starting it. Hi. Okay. So this is an example of a malignant MCA syndrome. You can see the massive infarction edema, and also there is sort of a midline shift as well. So මේ වගේ අයට අපි කරනවා decompressive craniotomy. Right. So we've talked about these things just for your notes, and carotid endarterectomy ගැන කතා කරා. And so if a patient with AF comes up with stroke, depending on the size of the infarct, you might, and the severity of the infarct as measured by the NIHS, you will delay the onset of anticoagulation. If it's a minor stroke or TI, you can start almost immediately 1 to 3 days after the event. But then if it's a more significant, bigger stroke, you might have to wait for about 2 weeks. Because there's a high risk of developing hemorrhagic transformation in a fresh infarct. That is why. So in a minor stroke, say you have given 2 dual antiplatelets, then clopidogrel is the favored drug. In stroke, in the long run, clopidogrel is what is favored as monotherapy. Correct? For life. Right. Okay. Any questions about that? Question number 6. Customer again.
Sir, do all patients with ischemic stroke get a carotid Doppler?
Yes. Yes. That's the standard of care.
Right. Okay.
Yeah. Three months. Samhara 6 weeks in or 9 weeks. So it's about 3 months is the maximum you give. Not really. So if there's a posterior circulation stroke, there might be no point in doing it because it's very difficult to do any interventions on the posterior circulation, vertebral. Samhalata karana puluwan if there's a good plaque in the vertebral territory wage ahunot ehema when you're doing a Doppler in the posterior circulation. Carotid Doppler එකක් එක්ක you do the vertebral artery Doppler as well in those sort of situations. Right. Okay. So question number 7 is on transient ischemic attacks, and amaurosis fugax is this transient sort of visual loss which can be associated with anterior circulation TIAs. That is true. Right. Now, this is very important. This is the ABCD2 score which we use for TIAs, and this is mainly intended to assess the future stroke risk. Right. So higher the ABCD2 score, the higher their future stroke risk. මෙතන මේ slide එකේ මම ඒක දාලා තියෙනවා මේවා කටපාඩමින් දැනගන්න ඕනේ නැහැ, but it estimates the stroke risk at 2 days, 7 days and 90 days, right? So that is the importance of the ABCD2 score in TIAs. So ඒකේ තියෙනවා duration of symptoms වැඩි වෙන්න the stroke risk is increased. නේ? Oops, sorry. Right. As with stroke, TIAs are very similar risk factors. So anything that causes an increased risk of atherosclerosis will cause TIAs as well. Right. So in TIAs, no thrombolysis, right? And we do use dual antiplatelet therapy, and it can reduce the risk of future stroke. Right. Now, හැමෝටම dual antiplatelet දෙන්නෙත් නැහැ, right? It all depends on the consultant who is managing, right? Because the guidelines are extremely strong evidence එකක් නැහැ, but there is an evidence that it does reduce the risk of future stroke and outcomes. There are 1 or 2 trials that show that. Okay. Any questions about that? Question number 7.
Sir, අර stroke එකකට පස්සේ මේ ඒ කියන්නේ minor stroke නෙමෙයි normal stroke එකකට පස්සේ අපි aspirin පටන් ගත්තම ඒක අපි low dose aspirin ද පටන් ගන්න
the dose is a bit variable, right? Based on the country. Now, for example, the UK we give 300 milligrams a day for 4 weeks, again 1 month. Sri Lanka වල අපි එච්චර high doses දෙන්නේ නැහැ, 75 milligrams වගේ තමයි දෙන්නේ, or 150 milligrams වගේ තමයි දෙන්නේ. The evidence doesn't show much of a difference in the dose that used, just you have to give some aspirin කියන එක තමයි. Yeah.
Right, and that's given for lifelong.
So aspirin දීලා clopidogrel වලට මාරු කරනවා in about a month's time. Yeah, and that is for life after that.
So
Chamath, antiplatelets you can start immediately, except in the case if you have thrombolized the patient second day first 24 hours ඇතුළත පටන් ගන්න නැහැ. දෙවනි දවසේ ඉඳන් you can start antiplatelets, right? But if you are not thrombolizing, first day onwards you can start, no problem. Right, now these pictures of CT scans of course show hemorrhagic strokes, hemorrhagic strokes. So anticoagulation generally, if the stroke is small or the TIA එකක් නම්, you can start within 1 or 3 days, right? But otherwise we usually wait for about 2 weeks. ඒ අතර කාලේදී antiplatelet ටිකක් දෙනවා. But 2 weeks වලින් විතර පස්සේ you start the anticoagulation. Right, and this is a CT scan, as you know, of a subarachnoid hemorrhage. Right. Right. Now, one of the commonest causes of hemorrhagic stroke are hypertension, right? That is a leading cause of hemorrhagic stroke. Typically, hypertension-related hemorrhages are seen in the basal ganglia and internal capsular region. That's very common, right? Of a hypertension-related ICH. Right. Now, the management of a hemorrhagic stroke is, there is no definitive thing that you can do. For example, there is no place of blindly giving FFP and tranexamic acid to all patients, right? There is no point in doing that, right? Of course, FFP can be given if the hemorrhage was caused by anticoagulation, right? But නිකං FFP, tranexamic acid, platelet, ඔයගේ දේවල් දීලා, there is no evidence that it improves outcomes. There is a current trial, I think, on IV tranexamic acid. They haven't published it yet. Well, wait to see if that only an tranexamic acid has a benefit, but definitely ඔවා නිකං blindly දුන්නා කියලා කිසිම තේරුමක් නැහැ. Right. Now, if you think practically, you would imagine that lowering the blood pressure aggressively would improve outcome, right, in a hemorrhagic stroke, because it prevents the hemorrhage from getting worse. But actually, looking at clinical trials, there is no evidence that blood pressure control, aggressive blood pressure control, improves outcomes. Evidence, it's a very controversial thing. Guidelines do recommend lowering of blood pressure in hemorrhagic stroke, but it doesn't translate to outcomes and mortality benefit. හරි, අපි කරනවා, නමුත් ඒක එහෙම කිය evidence එකක් නැහැ, ඒකේ benefit එකක් තියෙනවා කියලා. Right. There is no place for prophylactic anticonvulsants. I know that some neurosurgeons recommend phenytoin sodium after hemorrhage, but there is no place for that, right? Unless they have a seizure, you don't give prophylactic anticonvulsant to patients with hemorrhagic stroke. Right. Probably the only important management option occurs when you have a patient who has a hemorrhage like this in the posterior fossa, right? So when you have hemorrhage in the posterior fossa, this can cause hydrocephalus, right? Because it obstructs this very small channel of the cerebral aqueduct in the posterior fossa. So this can cause hydrocephalus. In this sort of situation, there is definitely neurosurgical intervention that is needed to reduce that hydrocephalus and intracranial pressure. So you should consider surgical evacuation, or at least, if you can't evacuate the hemorrhage, to go for reduction of ICP methods, right? Samada flap එකක් අයින් කරන ඔළුවෙන් ඔය එක එක දේවල් කරනවා. But yes, that is an indication for surgery. Don't refer all your patients, that is something that we do in the ward very commonly. එහෙම කරන්න එපා කියලා මේ කියන්නේ. Don't refer everybody who has a ICH to neurosurgeons, right? The only important thing they can do something is when this is hemorrhage is sort of causing increased intracranial pressure, midline shift, hydrocephalus වගේ තියෙනකොට, then they need to do something to reduce the intracranial pressure. Right. Okay. Any questions from this one? Number 8.
So in a posterior cranial fossa hemorrhage, would they intervene sort of
depending on
or after hydrocephalus?
නිකම්ම posterior ආවා කියලා මුකුත් කරන්නේ නැහැ, but if there's a complication, so you monitor these patients very carefully. If there's a complication, they would definitely intervene, or they should intervene. They resist most of the time, but you should press them to do something, because otherwise you can't, the patient will die definitely.
Right. Okay.
Right. Good. Right. Now the next question, question number 9, is on subarachnoid hemorrhage. So all of you saw the CT scan of subarachnoid hemorrhage, where this is called the very typical star sign. Neither you get blood in the basal cisterns, right? And this is called the star sign. Now typically subarachnoid hemorrhage you can diagnose from the history. Neither this causes a thunderclap headache. Yeah. So තුන්වෙනි එක හිරන් මේකේ තියෙන blood pressure control කරා කියලා you imagine there should be an outcome because it reduces the bleeding, but the clinical trials do not show any improvement of mortality or anything like that with blood pressure reduction. ඒ නිසා තමයි ඒක වැරදි. මොකද improves outcomes කියන්න බෑ. අපි කරනවා blood pressure එක අඩු කරනවා. It possibly reduces the hemorrhage size, but it doesn't improve the long-term outcomes of mortality. Right? So prophylactic anticonvulsants, there is no place, right, at all. පහ හරි. Yeah, should be considered කියලා නේ. Considered, and especially if there is a risk of increased intracranial pressure. The word considered is a very non-committal word, so you are thinking of it. Right. So yes, we're talking about subarachnoid. So thunderclap headache is a feature, right? When we're doing renal, I told you of this second MCQ statement that is right. Neither. So some patients with polycystic kidney disease can get aneurysms in the circle of Willis, and that can give rise to a subarachnoid hemorrhage. Right. Right. Now, how would you diagnose a subarachnoid hemorrhage? Right. Very simple. Diagnose subarachnoid. It's just a plain CT scan of the brain is your primary diagnostic test, or the first thing that you would do, right? Just a plain CT scan of the chest, the head, and brain. Now, this I might have told you in your appointments. If you do this CT scan within 6 hours of symptom onset, right? If you do it within 6 hours of symptom onset, and it is reported by a specialist with experience in reporting subarachnoid hemorrhage CT scans, right? And trials again, neuroradiologist කෙනෙක් කියලා. ලංකාවේ නම් එහෙමයි නෑ. But there are people who specialize in, but even neuroradiologist කියලා කියා ගන්න අය වැඩිය නෑ. If it has been reported by a specialist, right, and done within 6 hours of symptom onset, you almost can exclude a subarachnoid. Almost exclude කරන්න පුළුවන් subarachnoid එකක්. Right. So that is, the CT is so important in the diagnostic process, right? But the problem is if the patient will do the CT scan later than 6 hours, the blood that has now entered the subarachnoid space like this will start to break down or lyse, right? And you will not see it on the scan. The blood cells, they break down in the subarachnoid space. So if the patient, if you do the scan later and it is normal, you still cannot completely be sure that it is not a SH. Ne? So in these patients, you would do an LP for xanthochromia. But ඒක කරන්න ඕනේ පැය 12ක් විතර ගියාට පස්සේ තමයි ඔක පේන්න පටන් ගන්න. So you delay this LP to about 12 hours of symptom onset, and then you look for xanthochromia. So that is beyond 12 hours. තමයි ඒක කරන්න ඕනේ. Right. Okay. Hari. Right. Now, angiographic tests like CT angiogram or DSA are not used for diagnosing subarachnoid hemorrhage. When subarachnoid hemorrhage diagnose කරන්න බෑනේ එකෙන්. එකෙන් diagnose කරපුවා aneurysms විතරයි. Right? When you do an angiogram, either CT or arterial DSA එකක් වගේ කරනකොට, you can see aneurysm, but that doesn't prove that it has bled. අපේ ඔළුව ඇතුලේ aneurysm ගොඩක් තියෙන්න පුළුවන්. ඒවා bleed වෙන්නේ නැතුව. So CT angiogram and DSAs are not used for diagnosing subarachnoid hemorrhage. They are used mostly for planning treatment. In a patient with confirmed subarachnoid hemorrhage, you can look at the aneurysms and plan treatment. So that is mostly neurosurgeons that do these tests to plan their treatment options. But it is not useful for diagnose because ඒකේ subarachnoid hemorrhage diagnose කරන්න බෑ. It will just tell you aneurysms. කවුද දන්නේ aneurysm එක bleed වෙලාද නැද්ද කියලා. Right? So you not guarantee. So therefore it is not used in the diagnosis of subarachnoid hemorrhage. So the xanthochromia හැමෝගෙම කරන්න අවශ්‍ය නැහැ. It is if you do the CT scan late, it is normal, then you would consider it. Right. So, right. So how do you manage subarachnoid hemorrhage? One of the important things is that you need to perform interventional closure of the aneurysm, and there are various methods in which you do that. Right. In patients who have a delay for surgical or interventional treatment, antifibrinolytics like tranexamic acid may have a benefit, right? But that's only in people who have a delay for intervention. Right. Now, in all other cases, medically, a very dangerous complication of subarachnoid hemorrhage is vasospasm. Right? Vasospasm. And the problem is if you get significant vasospasm, they can get infarcts. Right? Take a mara ledak. Right? So post SH එක මඩිවට infarcts, because of excessive vasospasm. In these people, we would give them nimodipine as the treatment. Nimodipine. So, අපි සාමාන්‍ය nimodipine දෙනවා හැමෝටම because to prevent the excessive vasospasm. Right. Okay. If there is existing symptomatic vasospasm, you need to give antihypertensives and various other treatment options. Right. Rarely you can have hydrocephalus as a complication as well in certain subarachnoid hemorrhages. Because when the blood goes and blocks the ventricular drainage system, and that can give rise to hydrocephalus. So there again you need surgical intervention. So this is sort of an outline of the management of subarachnoid. So either the best thing to do is obviously go for intervention, like open කරන වෙලාවල් තියෙන සමහරවිට එක වයස නම්බරන් දාලා කරන ඒවා තියෙන. If there is delay in surgery or intervention, antifibrinolytics like tranexamic acid may have a role. And also the other important thing is we are very interested in preventing complications like excessive vasospasm following SH. And for that we need nimodipine. Rasika, there is no good reason for this observation that they are more common in hypertensive hemorrhages are more common in the basal ganglia. එම විශේෂ හේතුවක් මම දන්නේ නැහැ. Right. Nimodipine is used in the management කියන එක හරි. Okay. The last statement here is correct. Hari. Any questions about question number 9? Customer Haritana Tiyanada? Subarachnoid hemorrhage. Right. Xanthochromia is pathognomonic. Right. That's a strong word to use. CSF xanthochromia pathognomonic කියන වචනේ මම අහලා නැහැ වැඩි මිනිස්සු පාවිච්චි කරනවා. But you can, yeah. Samantha, right. So this the question that you're asking is very controversial, right? So හැමෝටම අපි LP කරන්න ඕනේ CT එකක් කරාට පස්සේ. Right? So the CT is negative. Do you always have to do an LP in a suspected SH patient? There's a lot of controversy about this. So people argue about this. If a patient comes with a history of subarachnoid and you do a CT scan within 6 hours, right? And then it's normal, you can almost exclude an SH. Right? LP කරන්නේ ඕනේ නැහැ. Right? තව patient එක පැහැයක් තියාගෙන ආයි LP එකක් කරන්න ඕනේ නැහැ. එහෙම කිව්වට ගොඩක් අය ඔබ කරනවා. ලංකාවේ මම දන්නේ නැහැ කොහොමද කියලා. දැන් but the UK වල එහෙම ඔක හැමදාම argument එකට හේතුවක්. හරි දැන් එක කට්ටියක් argue කරනවා පැහැයක් ඇතුළත you do the CT scan normal reported by a neuroradiologist normal නම් ලෙඩා ගෙදර යවන්න පුළුවන් කියලා. ඒකට සමහර consultants ලා ගෙදර යවනවා. හරි සමහර consultants ලා නෑ බයයි කියලා තියාගෙන LP එකකුත් ගහලා xanthochromia බලලා ගෙදර යවනවා. Nobody is clear about what exactly to do. But theoretically, if your patient comes with a history, a CT scan done within 6 hours, reported by a neuroradiologist or expert, normal, then you can discharge. But එහෙම practically කරන්නේ නැහැ හැම වෙලේම. ඒතර ඔය වගේ දේවල් ඕගොල්ලෝගෙන් අහන්නේ නැහැ. Right? Depends on the consultant and how bold the consultant is. Right. මෙහෙටිම නඩුදායි කියලා බයට හැමෝටම LP ගහනවා ඉතින්. මොකද ඔක ගැන ලොකු ආගියුමන්ට් ඉතින් හැමදාම යනවා ඉතින් සබ් ඩයරෙක්ටරේට් පේෂන්ට් කෙනෙක් ආව. LP කරනවද නැද්ද කියන එක. Right. Okay. Right. Right. So now we move on to the last part of this paper, which is on CNS infection. Right. And there are three important types of infections of the nervous system that we are going to talk about. And these are meningitis, encephalitis, and cerebral abscess. Oh, if you're doing an LP, you have to do a CT. Of course, LP ඉස්සලා කරන්නේ CT එක ගහනවම තමයි. Right? There is no doubt about that. Anyway, you should do a CT anyway before doing an LP. Whatever situation also. හරිද? So කවදාකවත් අපි LP ගහන්නේ නැහැ. Even if the patient comes late, you still do a CT scan before doing an LP. Right? Right. Now this slide gives you some sort of MCQ points about etiologies. I'm not going to read through all of this. This is for your reference. So various important risk factors and things that are relevant for these organisms that cause bacterial meningitis. Of particular note here is Listeria, right, which can cause meningitis at extremes of age, and also in pregnancy, as well as in people who are immunocompromised. So, එක පොඩ්ඩක් මතක තියාගන්න. Listeria, meningo, it is called meningoencephalitis, but you see this at extremes of age, pregnancy, and people who are immunocompromised. Right. Things like Staph aureus meningitis, gram-negative meningitis are common in hospital settings and related to neurosurgical procedures. Right. So this is for your reference. So worldwide, Streptococcus pneumoniae is the commonest cause of bacterial meningitis. Right. Listeria meningoencephalitis occurs at extremes of age, is right. The third statement also we have talked about, especially in pneumococcal meningitis. For that matter, any sort of pneumococcal infection, they can get acute adrenal insufficiency. If you got namakut kiwa, Waterhouse-Friderichsen syndrome කියලා. Right. So when we can clinically exercise the ICP, still you do a CT before LP. That is a good practice. Better safe than sorry. Or සමහර වෙලාවට මේ ගායනි ICP වල early stages වල papilledema එන්නෙත් නැහැ. Right? So you have to be very careful. So I would always recommend, if you are doing an LP, do a CT scan before. Right? Safe. Right. Right. Now, how do you treat bacterial meningitis? The antibiotic of choice is cephalosporins, third generation cephalosporins. So ceftriaxone is a good drug. Cefotaxime is a good drug. Right. So that is the antibiotic of choice. Right. Now, exceptions to this usual rule of using cephalosporins is, if you suspect Listeria meningitis, you have to add in ampicillin or amoxicillin IV, right? Because ceftriaxone or cefotaxime does not have activity against Listeria. So you have to use ampicillin or amoxicillin, right? The other important thing to remember is, in certain parts of the world, like South America, Japan, there are cephalosporin resistant strains of strep pneumonia, right? Cephalosporin resistant strains of strep pneumonia. In those patients, ලංකාවේ සමහර තැන්වල report කළා තියෙනවා. In those patients, we usually add vancomycin. If you suspect cephalosporin resistant organisms or culture cacao, cephalosporin resistant කියලා, then vancomycin should be added. So that's the usual exception to this rule. Usually ceftriaxone, cefotaxime works excellently well in meningitis, and that is the treatment of choice. Ampicillin should be added if you are suspecting Listeria, and vancomycin if you are suspecting a cephalosporin resistant strep pneumonia. Right. Another important principle in managing bacterial meningitis is, we often give them steroids, dexamethasone, ideally before the commencement of antibiotics. And this has been shown to reduce the long-term complications of meningitis, like cranial nerve palsy, which are due to the inflammation, not really due to the infection itself. It is due to the inflammation related to the infection. So, cranial nerve palsy. Some people have hydrocephalus because of this scarring and inflammation-related changes in the ventricular system, right? So, steroids are not contraindicated. We use them as a mode of reducing the excessive inflammation that occurs. And this can improve long-term outcomes and complications. Right, so this is a distributed video. So this slide is important. It gives you important epidemiology or MCQ epidemiological risk factor related stuff I have included in this slide. And then this gives you a nice, this MCQ is based on the etiology and some of the management principles of bacterial meningitis. Any questions?
Sir, what are the types of patients who warrant this steroid therapy?
If there's a clear-cut history of possibility of bacterial meningitis, yeah.
All
But
right,
if he has a question, could this be viral? Sure, but if there's a clear possibility of bacterial meningitis, you give steroids.
Okay, sir.
Right.
Thank you.
Right. Now, we were talking about LPs, and of course, bacterial meningitis, the primary mode of diagnosis is with CSF interpretation, and this I have gone through with you in your appointments, and you know this very well, the various characteristics of the CSF in etiologies of meningitis. Dextritis blood-brain barrier, that I don't know. Right. It doesn't halt it a lot because otherwise you won't be giving it. Right. Potentially, as it reduces the inflammation in the blood-brain barrier, it can cause a little bit of reduction of antibiotic penetration, but I don't think it's a major problem. Right. So this we have discussed about sort of the treatment options of meningitis. It was Staph aureus and gram-negative organism-mediated meningitis is almost exclusively in hospital settings. Right. True or false? So this is again a little bit of a discussion on the management of and diagnosis of meningitis. Low CSF glucose is characteristic of viral meningitis is false. So in viral meningitis, the organism doesn't multiply a lot inside, doesn't do anything inside the CSF. So they have a normal protein and a normal CSF glucose. This in contrast to people with bacterial meningitis, where the bacteria is actively multiplying within the CSF. So they use the glucose for that purpose. So there is low CSF glucose. Right. Now, viral meningitis can be due to HSV2, right? HSV1 usually causes encephalitis. HSV2 can cause meningitis, and it is known to cause recurrent meningitis. Not common, but can cause recurrent meningitis. Right. Now, for meningitis, the duration of antibiotic therapy varies from 7 days to 14 days, right? Depending on the whether you isolate an organism or not, depending on the organism itself, this can go up to 2 weeks, but it's definitely not 5 days, at least 7 days, right? Right. Now, last time when we did endocrinology, we talked about SIADH. So SIADH is caused by drugs. We talked about that the other day. Also, SIADH is due to pulmonary and brain pathology, right? Any infection, inflammation in the lungs or in the brain can give rise to SIADH. Hi. Now, there is a place for prophylaxis of meningitis in certain causes of meningitis, right? Especially things like Neisseria or streptococcal meningitis. There is a place for prophylaxis, but hammer meningitis prophylaxis දෙන්නේ නැහැ එක බොරු කතාවක්. හරි? Pediatrics වල තව ඔයගොල්ලන්ට ඕක ගැන විස්තර කියලා දෙනවා. So I'm not going to go into detail about that. Right. Okay. Right. So that is question number 11. Hari. Now moving on to question number 12, Lamai. This is on TB meningitis. Now, TB meningitis is very, very difficult to diagnose. That is the first thing that I have to say. It is exceptionally difficult to diagnose. And it can have a variety of manifestations. Some people come with just a chronic headache, nothing else, chronic headache. Occasionally, people can have focal neurological signs, and this is often due to these tuberculomas. These are ring-enhancing lesions in the brain, right? So these tuberculomas can cause focal neurological signs, right? Ashwa, yes, in the CSF in partially treated meningitis, you can get a lymphocytic infiltrate. That's right, yes. But still the proteins will be high and the glucose will be also be slightly lower than a viral. Yeah, but you will see a lymphocytic infiltrate, yes. Right. So in TB meningitis, we will have chronic headache as a manifestation. Some people come with focal neurological signs due to these space-occupying lesions. Another important problem in TB is that it causes scarring of the ventricular system, right? Scarring and narrowing of the ventricular system. And what does that cause? It can cause, like in picture on the right side, can cause hydrocephalus. So hydrocephalus is another important manifestation of TB meningitis because it causes scarring along the ventricular system. Right? Scarring, right. So regarding TB meningitis, very difficult to diagnose, may present with focal neurological signs. And because it also causes, because it is a chronic meningitis, it causes meningeal thickening and significant meningeal enhancement on CT scan. Right? So it's chronic meningitis can cause meningeal thickening. Right? Meningeal thickening is a common feature that you see, and also meningeal enhancement takes up contrast very well. Right. Now the next one, you have to be careful. So how do we diagnose this infection? Right? Diagnosis sometimes is purely based on imaging. Right? Purely based on imaging. Right? There are tuberculomas or suspected ring-enhancing lesions like this, right? Or hydrocephalus, right? Or chronic meningeal thickening and enhancement. Sometimes purely you'll have to go on the CT appearance still. If you are lucky, you will get CSF changes. So the typical pattern on CSF in TB would be a very high protein content. So in CSF, a very high CSF protein content. They will have a lymphocytosis, right? Lymphocytosis, right? Lymphocytosis in the CSF. Lymphocytosis. So high protein content with a lymphocytosis, and their glucose is low as well. Glucose kadu. Right. Now this slide says that gram stain percentage positivity can go up to 87%. That is rubbish, right? In the CSF, I have only seen one patient with a positive AFB, right? So I don't know where they're getting that data from in this table, but it is very rare for you to isolate an organism in the CSF in TB meningitis. I have seen maybe one person who had a positive CSF, AFB. So yeah, so if you're lucky, you will get changes in the CSF with high protein, low glucose, and a lymphocytic infiltrate. Isolating an organism is very unusual, very, very unusual. Now the third one is tricky because you can also, in the early stages of TB meningitis, you can get a neutrophilic infiltrate. So make a varadine. Commonly you see a lymphocytic infiltrate, but remember in the sort of early stages of TB meningitis, you can get a neutrophil predominance. So can cause neutrophil predominant is true. Right. Now the management of TB meningitis is extremely controversial, and we find that various people manage it in various ways. But general consensus is we treat it for longer, right? Usually 9 months, 1 year. 9 months to 1 year anti-TB. And we use intramuscular injections of streptomycin quite commonly as well. Right. Any questions about TB meningitis? ප්‍රශ්න මොනවද තියෙනවද TB meningitis ගැන? So remember, isolating organisms is very, very rare. I've never maybe seen one patient. We often go by the clinical history, the brain imaging findings. Maybe the CSF will show a little bit of a change. It's not straightforward at all. Right? Right. Okay. Right. 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 The next infection we will talk about is about encephalitis. Right? So encephalitis, the commonest cause, or at least the commonest කියන්න බෑ මොකද අපි දන්නේ නැහැ ගොඩක් viral encephalitis වලට හේතුව හොයාගන්න බෑ, but of course the most important form of viral encephalitis is herpes simplex encephalitis, right? Is due to HSV1 and not HSV2. Yeah, so tuberculomas are part of the meningitis spectrum, right? But remember, sometimes Kanika, without meningitis, you can get meningioma, tuberculosis only also sometimes, right? But most of the time they coexist based on our clinical experience. Right? Right. So herpes simplex encephalitis is due to HSV1, and because it involves the temporal lobes, right? Very commonly these patients present with altered behavior and memory, and also disorientation. Right. Right. It doesn't affect the basal ganglia, it actually affects the temporal lobes. Viruses that cause encephalitis like JE, West Nile virus are known to affect the basal ganglia regions, JE and West Nile virus. Right. Now, what do you see in the CSF? Right. The CSF is very useful because you can do the CSF and send off for viral PCR in the CSF. That's an important way of diagnosing HSV. So you'll have the typical viral picture of a lymphocyte increase, maybe a little bit of protein elevation, but no change in the glucose. Something that we see in herpes encephalitis in some patients is it causes hemorrhage into the CSF, right? So you have to be very careful to make sure that when you do this LP, you have to make sure it's non-traumatic. So in a non-traumatic LP, if there's blood, when you put it in whether it's traumatic or not, blood cells ගොඩක් තියෙනවා නම් that suggests or supports HSV encephalitis. Right? The causes and hemorrhagic CSF is true, right? Causes hemorrhagic top encephalitis, which can then seep into the CSF, causing a hemorrhagic CSF. Right. Acyclovir is a treatment of choice. කියන එක හරි. That is right. Right. Any questions about this one? Supun අහලා තියෙනවා. So yes, Supun, you're correct. In sometimes encephalitis, CSF is absolutely normal, right? But sometimes you get a little bit of lymphocyte and protein. සමහරට yes, visibly hemorrhagic වෙන්නත් පුළුවන් in herpes encephalitis, yes. Right, and of course this picture you can see the classical involvement of the temporal lobes on this MRI scan. Right. Okay. Now this particular slide is important for cerebral abscesses because it sort of gives you the etiology and important organisms that cause cerebral abscess. So Janit, no, acyclovir doesn't work for any other viral encephalitis. No, unfortunately, things like JE, West Nile virus, there is no treatment, right? You just have to wait for it to take its course and then work with what you're left with, right? Unfortunately, there is no definitive management. So gynae, sometimes it can be difficult to differentiate a TB, tuberculoma and abscess, right? Sometimes in the worst cases, we do brain biopsies as well, right? සමහරට එච්චර අමාරුයි diagnose කරගන්න brain biopsies කරන වෙලාවල් තියෙනවා. Right. So this slide is important. Again, I'm not going to read through this, but it gives you a important. Varicella encephalitis is rare, right? It doesn't cause a lot. It does work against varicella. I was talking in the thing of encephalitis, HSV encephalitis, අනිත් ඒවාට වැඩිය වැඩ කරන්නේ නැහැ. Varicella වල වැඩ කරනවා, but varicella වලින් encephalitis වෙන්නේ very very rarely. Right. And using the previous slide, you can answer a lot of the questions here, right? Make a right temporal lobe and cerebellum, right? Right. Now, multiple cerebral abscesses are well known to occur in HIV patients. And one of the important etiological agents there is toxoplasmosis. හරි ඒක බොහොම වැදගත් එකක්. In HIV හරිම වාතයක්. If somebody with HIV develops cerebral abscesses, it could be due to toxoplasma. Also TB TBත් එන්න පුළුවන්. HIV patient ලගේ tuberculosis උත් එන්න පුළුවන්. So sometimes it's again a mess to diagnose, right? So this one is true, right? You already know, Lamai, that multiple cerebral abscesses can occur in patients with endocarditis. That's a famous point, right? Famous point that we know, right? Because you can get parts of the infection, parts of the vegetation breaking off and going and lodging in the brain, right? All right. Now, cerebral abscesses are very difficult to treat, right? Very, very difficult to treat, right? We treat them with cephalosporins and metronidazole, but they are very difficult to treat, right? Very, very difficult and need prolonged courses of antibiotic therapy, right? So the cephalosporin metronidazole combination is good, right? සමහරට මේකට vancomycin උත් add කරනවා. Especially when you're suspecting a staph endocarditis related thing, you will add vancomycin also. The problem with treatment here in this context is that you need to give multiple antibiotics for long periods of time, right? Some 4 weeks, 6 weeks antibiotic therapy, right? And failing antibiotic therapy, sometimes surgical intervention is also needed, right? And you need to go in and take the abscess out surgically, right? So these are all problems when it comes to cerebral abscess. Sorry. ඔය එකපාරක් MCQ එකක් ඇහුවා මෙන්න මේකෙන්. ඒ නිසා ඔක පොඩ්ඩක් බලා ගන්න. Again, I don't know what you're going to get this time, but මේ වගේ unfortunate කටපාඩම් ඒවෙනුත් විභාගෙට අහලා තියෙනවා. හරි. Right. Right. Unfortunately, I had to go for a meeting now, but we've done the majority of stuff today, so we can do this before we start the next session. Yeah, or at the end of the next session, we can do these best response MCQs as well. Anyway, lazy then I very easy ones, right? So we will discuss most of these concepts. Right. Any questions from today's session?
Sir, surgical drainage එක මුලදීම consider කරන්නේ නැද්ද?
එහෙම කරන්නේ if there is midline shift or patient is unconscious, dropping GCS, yes. But otherwise, we go for medical management first. The poking around in someone's brain is something that you don't want to do, no? Unless there is a real indication for it, we try medical antibiotics first.
Sir?
Can.
Hello? Sir, regarding HSA, this means if patient is having features of brain communities, we can't, can we start patient on antibiotic and acyclovir without antibiotic?
Yeah, so if you have a suspicion, even a small suspicion that there is encephalitis, we can start the patient empirically on acyclovir. Right? Prashna.
Thank you, sir.
By confirmation එකක් ආවෙ නැත්නම් අපි සාමාන්‍යයෙන් නවත්තනවා ඒක. Yes, HSC can also be diagnosed with antigens, viral antigens. Yes. PCR කරන්න පුළුවන් නැත්නම් ඒව antigen detection kits උත් තියෙනවා. හරි. හරි චමත් එන.
හරි සර්.
හරි. ඊගාව සෙෂන් එක සිකුරාදා වගේ තමයි ගොඩක් විට.
හරි සර්. හරි. ඕකේ.
Okay. Right.
Thank you.
Right.
Thank you, sir.
Thank you, sir.
Thank you.